Everybody. My name is Eunice, and I am the program coordinator at Cancer Support Community. I am also a patient navigator at Northwest Medical Specialties. We are very excited to have you here tonight on a very important topic that is going to be presented by Sarah Sandifer, one of our nurses here at Northwest Medical Specialties. I wanted to give you guys a little bit of information about Cancer Support Community. Cancer Support Community is one of the largest, or actually it is the largest worldwide nonprofit organization. It is for anybody affected by cancer, whether you are a patient, a survivor, a family member, a healthcare provider, a family, a friend, a caregiver. It is open to everybody. And it is through this program that we are able to offer so many great different programs. We have presentations like this where they're educational. We also have support groups. We do social events. We offer, some health topics and just so many things that we hope that everybody enjoys. Just to give you guys a little bit about some housekeeping rules for today, rules for our workshop is that you can decide if you want your camera to be on or off. We do ask that everybody just stay muted throughout our presentation. That way it kind of eliminates that background noise. And if you do have any questions throughout, just go ahead and unmute yourself and speak up. You can also put them into the chat. We will have somebody that is going to be monitoring the chat and will get our presenters' attention. And that way you won't forget your question if you hold on to it. We will have opportunities kind of throughout where we'll kind of stop and then make sure that each sections we're able to ask the questions that are there. Another thing is we are going to be having a raffle at the end of the night. So everybody who was here tonight is going to be entered into that raffle to win a gift card. So the biggest thing to help us with that is if you can just please check your name that you have on your screen. Everybody should have, registered. So I already have your addresses where I will be mailing you the gift card if you are one of the winners or a winner. But sometimes it's hard, like if you only have like a phone number listed or you don't have your name there at all. If you are not able to change your name, if you can just please send me a message in the chat. And that way I have that information. The way you can change your name is actually if you highlight your name over the picture or not, you can right click and that'll let you update your name. Let's see. I think that, and the best viewing option is going to be the speaker option, and that'll just let you be able to see the speaker and the presentation. I think that's pretty much it. This workshop is being recorded. So in a couple of days, I will upload it onto the Northwest Medical Specialties YouTube page, but I will also be emailing everybody some educational material that goes along with this presentation, and a copy of the PowerPoint presentation and also the link to watch the video, just in case you have any questions later on and you want to go ahead and refer back to it. All right, I think that's it. I'm going to pass it to Catherine, who is going to present our speaker tonight.
Hi guys, my name is Catherine and I'm a committee member of Cancer Support Community, and I'm also a research assistant with our Northwest Medical Specialties Research Department. Thank you guys so much for coming to our presentation today. I'm going to introduce a little bit about Sarah before she starts her presentation. Sarah began her career as an oncology nurse 13 years ago at St. Joseph's Medical Center in Tacoma. In 2012, she came to Northwest Medical Specialties to work as a clinical research nurse. As a very curious person, Sarah spent a lot of time studying how cancer works and how the new drugs we try in clinical trials use specific targets to stop cancer growth. This curiosity led to a new role as Precision Medicine Coordinator in 2016. And in 2020, Sarah completed City of Hope's intensive course in genetic cancer risk assessment. Sarah is now working as our precision medicine manager, working closely with our physicians at Northwest Medical Specialties to coordinate biomarker testing for our patients and to enroll patients into clinical trials based on their testing results. Sarah is married with 3 grown children and currently lives in Tacoma. And without further ado, I'm going to pass it along to Sarah.
Thank you so much, Catherine and Eunice, for that introduction. That was fun. Thanks for coming, everybody. I'm excited to have you all here for this session. Cancer Support Community has put together these slides, but we'll be going through them together. And Gilda's Club also, I think, helps sponsor this presentation. So just to go over what we're going to review tonight, we already started with the introductions. We'll do a little bit of a just introduction to what precision medicine is. I think it's a term that's being used a lot. You see it on television or you read about it in the news, but we'll define it for the purposes of this presentation tonight. And then we'll talk about biomarker testing, how your physicians use those biomarkers in figuring out the best treatment for cancers, what types of targeted therapies there are, the costs, which are significant, of both the testing and the therapies. And also we'll go over when genetic testing is appropriate for you and for your cancer to help us find the best treatment. These slides were put together by Sloan Mess back in December, and I've looked over them and added a few things, but for the most part, I stuck with their slideshow. It was developed by the Cancer Support Community. They do develop this independently, but they have other people review it. Cancer Support Community does have final control over their content, and Merck, AbbVie, and Foundation Medicine all sponsored this particular program. And I was asked to do this presentation by our local CSC committee. I don't have any financial relationships at this time or affiliations to disclose, and I'm not being paid by AbbVie, Foundation, or Merck. So the question of the hour, obviously, is what is precision medicine? I hear this term thrown around a lot. You'll sometimes hear it talked about also as precision oncology or personalized medicine. But when it really comes down to it, it's a newer approach to cancer treatment, which is, we've always wanted to look for what the best way is to treat someone's cancer, but now we're looking even closer at the individual level. What's the best way to treat your cancer, your specific cancer? The treatments that we give for cancer can differ significantly from person to person. And the more we know about you and your particular tumor, the better chance we have of finding a treatment that's going to work for you. So like I said before, sometimes it's referred to as personalized medicine. Precision medicine is personal. We want to find the right treatment for every patient to the best of our ability. So before we were using this model, we always referred to cancers by their point of origin. So, and we still talk about cancers this way, right? Like you have lung cancer, or you have breast cancer, or you have colorectal cancer, or maybe if you have a hematologic cancer like lymphoma or multiple myeloma. We used to treat all of those different types of cancers with the same lines of therapy. So everybody who had lung cancer would start with the same kind of treatment, and then they would go on to the same second line of treatment and the same third line of treatment, because we didn't know that they weren't all the same. But now we do. We know that there's differences between all of those, within all of those different kinds of cancer. And so with precision medicine, we don't treat them all the same anymore. We try to find the specific subtype of cancer using what we call biomarker testing. And results of these tests can help us know, help your doctor know which treatment is likely to work best for you. One of the biggest areas where this has changed has been in lung cancer. Not even that long ago, everyone with stage 3 or 4 lung cancer received the same treatment. But today, doctors know more about lung cancer, and they know that there are different reasons that your cancer might be growing compared to a person with the same stage and type of cancer as you in the next room. So there's more information that we need to know about your tumor to make sure that we're giving the best treatment. So a precision medicine diagnosis could involve doing tests that are not always routine at some doctors' offices. You might have to ask for those tests. Here at Northwest, our doctors are pretty aggressive with biomarker testing. So most of our physicians use this to determine the best treatment. This workshop's just going to help you be more informed so that you can ask questions of your doctor if you're not sure that this has happened for you. And just, I think it's important for all of you as patients and us as the staff taking care of you to understand this whole idea a little bit better as we move forward into kind of a whole new era of treating cancer. So this slide is really kind of just reviewing what I just said. You know, it's a newer way to find the right treatment for each patient based on the cancer subtype. Biomarker testing is just one of the ways that precision medicine is practiced. And biomarkers can be several different things. So the first step in using precision medicine is usually testing biomarkers on a pathology sample of a tumor from a patient's cancer. So those biomarkers could be genes, which are within the DNA of the tumor. It's a specific change to the genome of that tumor. It's not a change to your DNA, so that's important. Your DNA that you were born with stays the same throughout your life. That's called your germline. It's your personal DNA, but your tumor's DNA is different, and that's part of why it's a cancer. It's not your normal cell. It's not working the way it's supposed to. It has mutations in it that are causing it to grow and be a cancer cell. So we're looking at changes specifically to your cancer cell's DNA or to the proteins on the outside of your tumor that can help us match a therapy that could work best for you on your specific cancer. Sometimes we refer to biomarker testing with a lot of different terminology. So you might hear this called molecular testing. You might hear it called tumor profiling, or somatic testing, or genomic testing of your cancer cells. The doctors refer to it in a lot of different ways. Here at Northwest, I think most of the time they'll call it molecular testing or next generation sequencing. So those are some terms you might hear from your doctor if they're talking about sending your tumor to a lab to find these mutations. In order for us to do biomarker testing, we have to have a sample of your tumor. So there's a couple ways that we can do this. The most common way that we're doing it right now is to use a sample from your biopsy. So either your biopsy, or if you had surgery for your cancer, we'll take some of the pathology left over from your surgery, and we will send that off to a lab. The lab is going to break that tissue down, and it takes usually 10 to 15 days. They will look at it closely. They won't, the machine will. It runs through a next generation sequencing machine, and that machine is specifically looking for alterations in the DNA of the tumor. More recently, in the last few years, the technology has grown to the point that we can actually pull DNA from your tumor out of your bloodstream. So we have testing now where we can use blood samples to look for circulating tumor DNA that's breaking off from your tumor, wherever that may be, that's running around in your bloodstream. And we can look for these same mutations in that circulating tumor DNA in your bloodstream. So in those cases, we would take 1 or 2 tubes of blood in the lab with our normal lab techs and send that off for the same type of sequencing, and they would look in your bloodstream for those same kinds of mutations. Right now, with bloodstream testing, we're not able to find quite as many mutations because there's a limit to the amount of DNA that we have to test. You certainly, hopefully, do not have as much tumor DNA running around in your blood as you do in the actual tumor. And there's also some more complicated mutations that are hard to find on blood samples. But we're able to use this on patients whose tumors are dividing rapidly. If your tumor is not kind of sequestered away in your brain or somewhere where it's not shedding a lot of DNA into your bloodstream. It's also can be harder if you have bone-only disease because those tumors tend to divide less rapidly. And again, they leave less of a DNA fingerprint in your bloodstream. But if you have a tumor somewhere, or the doctor suspects you have a tumor somewhere that's growing, a lot of times that DNA will show up and we can test it that way, which is nice. It's nice to have a less invasive option than having to have a biopsy to get this information. Some of the tests that we look for, if you have, say, lung cancer, we'll be looking for EGFR or ALK or ROS1. These are all mutations that now have treatments if you have lung cancer. If you have colorectal cancer, we'll look for BRAF or KRAS, and those are mutations that can really direct the doctors into what treatment you need. And many of you have probably heard of the hormone receptors we test for all breast cancer tumors, which are estrogen, progesterone, and HER2. It's standard of care for every breast biopsy that we look to see if the cells have those markers on them. So we kind of went over this a little bit, the alternate names. There's a couple more on here: comprehensive biomarker testing, gene-based cancer testing, mutation biomarker testing. There's just a lot of names, and it can make it a little bit confusing when you're trying to figure out whether your doctor's ordering this for you or not. It also can be confusing when you get the statement from the insurance, because your insurance explanation of benefits might just say genetic testing, which doesn't really tell the whole story and doesn't necessarily give you a good idea of exactly what testing your doctor ordered. That can be frustrating as a patient, for sure. So what is a biomarker? It's a sign of disease or abnormal function that can be measured in your blood, tissue, or bodily fluid. We can test biomarkers on things like pleural fluid if you've had pleural effusions that have been drained, or ascites if you've had ascites that's been drained from your belly, if you have a cancer that's doing that. The biomarkers that we're looking for can be proteins, genes, or gene mutations. So there's kind of multiple things that we're looking for with this type of testing. So going back a little bit in review, the new way that we treat cancer is based on the subtype of your cancer rather than just the type of cancer. Even in cancers where we don't have as many great treatment options like pancreatic cancer, we're now looking for biomarkers like BRCA mutations because there are treatments that are different for pancreatic cancer if you have a BRCA mutation than if you don't. So we are testing for that now in most of our pancreatic cancer patients. The cancer type you have is named for the organ. So like we talked about at the beginning, if you have breast cancer, we still call it breast cancer. But amongst breast cancer, there's lots of different kinds of breast cancer. There's triple negative breast cancer, or there's hormone positive breast cancer, or there's HER2 positive breast cancer. That's the subtype. And it's similar for lung. Lung cancer can have any of these 4 mutations on the screen. It can have PD-L1 protein receptors. It can have HER2 receptors, EGFR receptors, and NTRK receptors. So those types of biomarkers are the things that we're looking for to help figure out the best treatment. And this field is changing all the time. So for us in the research department right now, we have clinical trials with like 15 arms for biomarkers that don't necessarily have approved treatments yet, but we're doing studies so that treatments can be approved for those biomarkers. So we're spending a lot of time in research looking for biomarkers and trying to match you guys as patients to potential clinical trials that could target biomarkers where there's not an approved therapy yet. So we're looking at this subtype all the time. I mean, it's something that we're constantly screening our patient charts, looking for better treatments, looking for clinical trial options for people, just looking at the subtype. This is a really reviewing slide, but we'll go over it anyway. Basically, the point is that biomarker testing is it can be an important part of your cancer diagnosis. And for some cancers, it's required in order for us to even get your standard therapy approved. For lung cancer, we need to show that you don't have a mutation in order to give you a standard therapy. Otherwise, they want to know why you're not getting a targeted therapy, because there's multiple targeted therapies for lung cancer. In colorectal cancer, there's certain treatments we can't give unless we know that you're negative or know that you're positive for certain biomarkers. So I'm sorry about my dog. He's freaking out downstairs. But it's an important part of your cancer diagnosis, and it provides us with the information we need to really make sure we're getting you the best treatment for you. And that's why they call it precision medicine, because it is individual for every treatment. These biomarkers help your doctor diagnose your cancer, predict how quickly or slowly your cancer might progress. So sometimes they can impact prognosis. They help your doctor decide which treatments will work best for you, and they help us identify clinical trials that you could potentially participate in that might offer a benefit for your disease. So on this slide, it's just talking about what biomarkers can tell doctors to. So again, I feel like it's reviewing again a little bit, but it does, some of these mutations tell the doctor that your cancer might be more or less aggressive than a different type of cancer. So there's certain mutations that we're looking for, or biomarkers that we'll find when we test, that the report will say that this biomarker has correlated with a poorer prognosis or a better prognosis for disease. And that's helpful for you to know as a patient, compared to other patients with my kind of cancer, am I likely to do better or worse? Am I likely to respond to this treatment or not? It helps you have a little bit more of an idea of what to expect going forward. And we also use biomarkers to make predictions about risks of developing cancer. So with germline mutations in particular, if you've inherited a mutation, we might be able to screen you for a cancer that you're at higher risk for and catch it early before you are in a position where you're dealing with a stage 4 metastatic disease when it's still completely curable. Some examples of biomarkers that definitely change treatment options. We talked a little bit about breast. So there's ER and PR, that's estrogen and progesterone receptors. HER2 receptors, there's BRCA1 and BRCA2 mutations. These BRCA mutations can be present in your tumor, or they can also be present in your germline. And if they're in your germline, it means you've had it since birth, you've had that mutation. And it can be passed along to your children. So that brings up a whole nother set of questions that need to be answered as far as your family goes. But not every cancer is inherited by far. Lung cancer, right now we're testing for EGFR, ALK, ROS, RET, BRAF, MET, PD-L1, and HER2, which is not on this list. Colorectal cancer, we look at the RAS genes, KRAS and NRAS, BRAF, PIK3CA, and MSI. And we do actually look for PIK3CA and breast cancer as well now, because we have an approved therapy in second-line hormone positive breast cancer for PIK3CA mutations. For GIST tumors, we look at PDGFRA. Leukemias, we're looking at the Philadelphia chromosome, or the BCR-ABL gene is what you'll hear the doctors call it. 17p deletions, TP53, FLT3s, IDHs, NPMs. These are a lot of initials that sound like alphabet soup. but they're very important when we're trying to make sure you're getting the right treatment. And this list is by no means exhausted, but these are just some of the different cancers that we're looking for these very specific biomarkers. And we do have approved treatments recently within the last few years where it doesn't even matter what kind of cancer you have. If it's microsatellite unstable, or if your mismatch repair genes are deficient, which is not something that I expect you to know or understand right now, but we're looking for that with biomarker testing. If you have that, or if you have an NTRK mutation, it doesn't matter what kind of tumor you have, there's therapies approved for any solid tumor that has those characteristics. So it doesn't matter if it's lung or breast. What we're looking at is just the biomarker because we know the treatment can work regardless of where it is. So some good questions to ask your doctor about biomarkers. Ask them if your type of cancer has biomarker tests that are recommended. So we use various guidelines for this. Like almost every type of cancer has their own committee that makes recommendations. But we typically, most insurance goes by the NCCN guidelines, which is a national organization that looks at the research and which biomarkers have approved treatments. And so when should we be testing? And they make recommendations for which types of cancer should be tested and at what points. Do we test early stage cancers? Do we only test metastatic disease? When are we looking for these biomarkers and what is recommended? So we look at those recommendations, and it's a good thing to ask your doctor, does my type of cancer have recommendations for biomarker testing that should be done? You can ask your doctor which biomarkers they're going to be looking for. And then what were those results tell you? Is it going to tell you about a different treatment that's available? Is it going to give you information about your prognosis? Is it going to tell you if this is something that you might pass down to your children? Like, it's important to know what the reason is and what they expect to find out from that test. If they tell you you've had biomarker testing, then ask about the results. What did that tell you? How has that changed my treatment? Or how does that impact where we're going from here? All right, we're going to take a short break for questions, or long, however long you guys need. Does anybody have any questions specific to the biomarker portion? You're so quiet. Okay, I'm going to assume I did an amazing job explaining that and everybody gets it 100% and you'll pass the test at the end.
I have a question.
Yay, good.
Okay, is a tumor marker the same as a biomarker? 20 years ago, they used to call the testing they did after you had cancer treatment, they would call it tumor marker testing. Is that the same thing as biomarker?
It's actually not, but that's a great question. So we have tumor markers for certain kinds of cancers, and those are antigens that we find in the bloodstream that we're able to do a blood test and get a result for. So an example is in like breast and sometimes ovarian cancer, we'll test CA, which stands for cancer antigen, with a number after it. So CA 15-3 or CA 125. In pancreatic cancer, we're usually looking at CA 19-9. In GI cancers, we're often looking at CEA. Those are all examples of tumor markers like you're talking about. And it is a good example of kind of personalized medicine because everybody's tumor markers are unique to them. We can't compare your tumor markers to the patient next to you, even if they have the same one, but we can compare them in you over time to see if they're going up or down and if that correlates with your treatment. So it can help your doctor have an idea if your treatment's working. So if traditionally your tumor markers have gone up as you're progressing and gone down when you're responding to treatment, then they can use that and test it periodically to give them an idea in addition to your scans and other tests that they're doing to look at your cancer, how you're responding to treatment. So that was a really good question, and it is something we do still use as part of your care.
So I have been told by my doctor that they do not use tumor markers, that they have too many false positives and false negatives. Do you agree with that?
I think it's really different for every patient. you kind of have to test it with each patient to see if it goes up and down. They can go up for many reasons other than progression. So if you have an infection, sometimes your tumor markers will go up even though your cancer is not getting worse. Sometimes some people's will never go up even though their cancer is significant if they just don't have that tumor marker. So it's not something like in research and clinical trials, we typically don't use them because they're so different from patient to patient. Like I've had patients whose cancer looked very similar to another patient's in terms of the subtype and where their disease is. Maybe it's mostly in their bones. And one patient's tumor marker might be 4,000 and the other one might be 30. So it makes it really hard to compare. So some doctors choose not to use them.
So it's very individual, it sounds like.
It's very individual. It's truly, it's not what we would call an objective marker that we can count on to tell us what's happening with your disease, but it can be part of the picture. So some of our doctors use it to just give them another hint, right? So to try to stay ahead and see what's going on.
Thank
Yeah,
you.
And so that's done through the blood test.
Yep.
Right? And so if one is getting a monthly blood test and you get your test result with all kinds of different pieces to it, that's what you call biomarkers. Or
the monthly test is usually a tumor marker. Biomarkers we do with your biopsies, and then a little bit if we're going to do the blood test, it's usually not monthly.
okay.
It's spread out a little more.
Question.
Okay.
Not every breast cancer is a tumor. What about the cancer that might be a mass, not a solid tumor?
Well, we still tend to we put breast cancer in the category of a solid tumor as opposed to what we would call a blood cancer, which is a liquid tumor. So breast cancer in general is referred to as solid tumor, even though, as you said, sometimes it's on your skin or it's in your lymph nodes, or it's not necessarily an actual tumor that you could feel, but we still would call that a solid tumor.
Thank you.
Yep. No, that was a great question. The hematologic cancers are a little bit different, and the biomarker testing can be a little bit different. We can do biomarker testing for hematologic cancers on bone marrow biopsies, in some cases on blood samples. And we can do testing on those for specific mutations in those cancers as well. But it does look slightly different than when we're doing it on a tumor sample for a solid tumor. Anybody else? All right, so now we're going to talk about targeted therapies. So if you get this test done and it comes back with what we call an actionable result, then your doctor may try a targeted therapy to treat your cancer. These are newer kinds of cancer treatment, although some form of these has been around for quite a while. But it targets a specific cancer subtype. And they're only going to work on the subtype, although we're learning more about that too. And we have trials now that are looking to see if they work in more subtypes than we thought they might. So targeted therapy drugs, the goal with these is to keep the cancer from growing and spreading by targeting the specific mutations on your actual cancer cells that aren't on all the other cells in your body. So the hope is that means you'll have less side effects and less harm from the cells that don't have cancer in your body, because we're hoping that these targeted therapies are really targeting your cancer cells. The side effects can be different than your standard chemotherapies that are attacking all of the rapidly dividing cells in your body. These targeted therapies are better able to attack the cancer cells and leave the healthy cells alone. It doesn't mean that you won't have side effects. You have to remember that even your cancer cells are part of your body. So even when we're targeting just your cancer cells, there's going to be side effects to that. Cancer subtypes are identified by the presence or absence of a biomarker. We have some targeted therapies that don't require biomarker testing because in some cases we know the biomarker is always present in a certain kind of cancer, like in CML, chronic myeloid leukemia, we know that the BCR-ABL gene exists in those cancer cells, but not in normal tissue. So we can target that gene because we know it's always there in that type of cancer. We don't even have to necessarily test for it, but we do because we can use it as a tumor marker to figure out if the treatment is working. The doctors are going to use this testing to match targeted therapy drugs to your subtype. And we can't guarantee that it's going to work or that it's going to work for a long time. But it is more likely that it'll work against a biomarker that you have than that it would work in a patient that didn't have your biomarker. I don't love this slide. We were talking about it before the presentation tonight. But I think, what it's trying to say is that, there's 5 different ways that targeted therapies work. So the first one is by finding and tagging the cancer cells. So it's going to mark it. The second one is by destroying them directly. So I guess they should have, pointed a tank right at the word cancer for that. The third way is by cutting off the blood supply to the tumor. So all tumors require a blood supply to be able to grow and do what they're doing. And if we can figure out a way to stop that blood supply, it can starve it from the nutrition to grow as quickly as it's trying to do. The fourth way is by cutting off the hormone supply to the tumor. So we have lots of tumors, prostate and breast and ovarian in particular, that use hormones to grow. So if we can cut off that hormone supply, then we can slow the growth. And then the fifth way is by taking the brakes off the immune system, and those are called checkpoint inhibitors. We'll go through each one of these. So the first one was finding and tagging cancer cells. When the targeted therapy actually sticks to the surface of your cancer cells, they act as a tag. And it makes it easier for your immune system to find and destroy those cells. So on the outside of your cancer cells and your normal cells, there's all kinds of little protein receptors. They're there normally. They're used for all kinds of normal bodily functions. But when we know they're there and we know they're abnormal on your cancer cell, we can target those particular little protein receptors. We can get a drug that's going to attach to it and make it basically show up to your immune system and raise a flag saying, hey, I am an enemy, please come and kill me. And that makes it easier for your immune system to destroy your own cancer cells, which is fantastic when it works. The second way that we use targeted therapies is to destroy the cell directly. So instead of, finding the cell and marking it for your immune system, it's going to stick directly to that receptor or go into the cell and kill it directly, which is also a fantastic way to get rid of a cancer cell. So right now we're testing a lot of drugs, and there's some drugs marketed that we call antibody drug conjugates. So if we know that outside of your tumor cells has like HER2 receptors on it, we can take a HER2 antibody that'll stick to those HER2 receptors and attach a cytotoxic killer drug to that antibody and put it in your system. So it's only going to attach to those HER2 receptors, and then the drug goes in and kills those cells that it's attached to and avoids all of your other healthy normal cells. So that's always good news. The third way is by cutting off the drug supply to the tumor. So we call this angiogenesis, blood vessel growth into the tumor. And there are certain kinds of cancers where the blood supply to the tumor, like they grow blood vessels quickly to try to nourish those cancer cells and get them to be able to divide and grow as rapidly as possible. So we do have certain treatments that go in and block that angiogenesis and keep the blood supply from being able to feed the tumor, which slows it way down. Sometimes, like we talked about, and like most of us have heard about for breast cancer, hormones are the fuel for those cancers to grow. So many breast cancers are fueled by estrogen or progesterone. And when that's the case, you will get a therapy that will stop the estrogen from being able to feed your tumor, that stops those hormones from being able to feed them. And we go about that in multiple ways. We'll try to block estrogen production. We'll try to block estrogen reception so that it can't get into the tumor. So, we do everything we can to cut off that hormone supply that's telling the cancer to grow. And then the last way is by taking the brakes off of your immune system. So sometimes there's a couple different things at play here. Sometimes you'll have mutations that mutate the genes that are there to keep you from getting cancer. Because, for most of your life, your immune system takes care of any cells that go haywire. It's like, oh, that one's not normal. Wipe that thing out. And we have genes that go along, and their whole job is to slow down the growth of any abnormal cells and destroy them. But if you get a mutation in one of those tumor suppressors, it means that your cells are more likely to go haywire. They're more likely to do things they shouldn't be doing. They're more likely to become a tumor or become malignant. So if we can take the brakes off your immune system, then we can help your immune system find those cells again and destroy them the way that it did before. We call these checkpoint inhibitors, and you've probably heard of them because they're being directly marketed on the television quite a bit. So some examples are Keytruda or Opdivo or Yervoy, Tecentriq. Those are all checkpoint inhibitors that are currently being marketed to patients and are approved in multiple different kinds of cancers. Cancer use, go ahead. Did somebody have a question?
I'm sorry, I coughed. No, I forgot to turn I forgot to turn it off. Sorry.
It's okay. It's okay. So cancers use those checkpoints to kind of put on a little invisibility cloak from your immune system so that they can keep growing without your immune system doing what it's always done and wiping them out. And we can now give checkpoint inhibitors that take off that invisibility cloak and help your immune system to find the cancer and attack it and kill it the way that it's supposed to. The side effects from those treatments are different than the side effects from chemotherapy, but it's, it still is a big jump in the way that we're treating cancer, that we're able to find ways to get your own immune system to fight it instead of just always having to throw toxic chemicals at you. So we're doing our best to try to get less toxic, more effective therapies, and this is one of the ways that we do that. So like we talked about before, the targeted therapies can have different side effects than your average chemotherapy. Some common side effects we see with targeted therapies are rashes. For whatever reason, when we're telling your body to target cancer cells, sometimes it targets your skin cells. So we can see a rash. It's usually mild. It can get worse within the first weeks of treatment. And there's certain types of treatments like EGFR inhibitors that have a much more significant rash that can really be a problem and make it difficult for you to get your targeted therapy. But we work really hard to try to control those symptoms. Sometimes we have to hold your dose or reduce your dose while you recover so that we can get you back on the targeted therapy at a dose that's tolerable. Dry skin and itching, fatigue is a big one. I mean, I don't know if I've heard of a cancer treatment yet that doesn't cause some fatigue, maybe Herceptin, I don't know. But almost every treatment we give, whether it's targeted or not, causes some kind of fatigue. And I think it's just, it's going in there and attacking cells and your immune system's reacting to it. And so fatigue is just one of the things that goes along with that. We find that the best treatments for fatigue is movement. So the more that you as a patient can keep moving, the better you'll be able to get past that fatigue and keep doing the things you need to do. Some patients will get a flu-like reaction. So like any other drug, you can have allergic reaction, but you could get fever, chills, and diarrhea. And I would say diarrhea is probably one of the other most common side effects of these targeted therapies. It's especially the oral targeted therapy drugs. They have to go through your GI system for you to absorb them. And kind of as a result of that, diarrhea often can come along with it. We have good treatments for diarrhea, but you have to be willing to follow the doctor's instructions, which can usually involve more Imodium than you think a person should ever take. So when your doctor says to take it, take a lot of it. Sometimes when you have side effects to the treatment, it's an indication to us that the therapy is working. So lung cancer patients who get a skin rash while taking EGFR therapies, we found are more likely to experience, a better response to that therapy compared to patients who don't have a rash. And patients who are on a specific FGFR targeted drug called erdafitinib, they get high phosphorus in their bloodstream. And we found that if you don't have high phosphorus after taking that drug, it doesn't work on your tumor either. Like your body's not metabolizing it in a way that's going to be effective. So sometimes the side effects help tell us if it's going to work for you or not. And I think the key part of side effects of targeted therapy is working closely with your doctor and the triage nursing team to make sure that if your side effects are becoming a problem and are difficult to tolerate, that you're communicating that clearly with your team, because there's often things we can do to make sure that you're able to tolerate the treatment safely and still get the benefits of the treatment without being miserable or having to go to the hospital or something like that. We can hold the dose or reduce the dose and not have to completely stop and change to another therapy if you let us know what's going on so that we can try to help and control the symptoms. Sometimes we use targeted therapy in combination with other treatments. So it's fairly common for us to give a targeted oral therapy, maybe in combination with a chemo or with radiation, even with immunotherapies or hormone therapies. So don't be surprised if you end up with more than one thing at a time. And this is true for a lot of our clinical trials as well. We have a lot of studies right now that are looking at like an immune therapy combined with a targeted therapy, or a chemotherapy combined with an oral targeted therapy. Here's one example. 1 in 5 patients with breast cancer have tumors with high levels of HER2. Those lead to high levels of the HER2 protein on the outside of the cancer cells, and that helps it grow. So prior to the 90s, HER2 positive breast cancers were the worst prognosis you could have. They were very aggressive. The tumors grew quickly. These patients did not survive for very long if they had advanced or metastatic disease. But for the last 20 and more years, they've worked really hard to create targeted therapies for HER2 positive tumors. And now we have multiple drugs that target that HER2 protein receptor, and it's completely changed the prognosis for patients with HER2 positive disease. They're much more likely to survive for longer than other patients now, whereas even just not that many decades ago, this was a death sentence. So we've come a long way. It's exciting. So here's some questions to ask your doctor about targeted therapy. If your doctor is talking about it, find out what is the name of it, what kind of drug, what biomarker is it targeting? Why do you think this is going to work for my cancer? Like, do I have the right biomarker for this treatment? Find out where and how you're going to get your treatment. Is it oral or is it IV, and how often is it going to be? And then for sure, you need to know if there's anything special to know about handling that drug. So some drugs are still cytotoxic and need to be handled carefully, and you need to make sure that other people aren't touching them. Do you need to take them at the same time every day? Do you take them for certain days and then stop for certain days? So we have quite a few treatments where you take it for 2 weeks and then you take a week off, or you take it for 3 weeks and then you take a week off before your next cycle. It's really important to clearly understand the directions for how to take your targeted therapy. If it's an IV or a shot, you want to know how often you're going to get treatment. Is it every 3 weeks, every 2 weeks, every 4 weeks, every single week? Those are questions you're going to want answers to during your chemo teach or when your doctor's talking about switching you to a targeted therapy. You also want to spend your chemo teach time talking about the side effects that you can expect and how to manage them. It's important to have medications at home ready to go for side effects that we expect. So if diarrhea is a common side effect, you want to have your Imodium ready to go. If nausea is a common side effect, you want to have your nausea meds at home and know, which ones to take at what point and when do you need to call the doctor to have something more done. If rash is common, when do you call the doctor and have them look at this to make sure that you don't need additional medications or creams or steroids to slow that rash down. You want to ask your doctor if you're going to get it alone or in combination with other therapies, and how long is it for? Is it for as long as it's working? Is it for a specific amount of time? How long are you going to be on this targeted therapy? So for all of the optimism and excitement about precision medicine, there are limitations. We're still doing research. We're still learning. We're still growing. Some of the limitations are that it benefits some people, but it doesn't benefit all people. If you don't have the right biomarker, it can be very exciting that we've got great treatments for HER2 positive breast cancer. But if your cancer is triple negative or not HER2 positive, then you're not going to benefit from that treatment. It's not going to be right for you. It wouldn't help you. Not all subtypes have a targeted therapy. So I've, reviewed probably thousands at this point of molecular reports back from the lab that don't have a biomarker that we can target. And, we're always looking for something. We're always hoping for a target for a biomarker. But we don't have biomarkers for every cancer, and we don't have targeted therapies for every biomarker. We have lots of breast cancer patients right now with ESR1 mutations, and they're developing drugs for those ESR1 mutations, but they're not out yet. So we don't have a targeted therapy for that mutation. It's, we're still learning and growing and developing and trying to get more therapies. Even if your tumor has the biomarker that matches the targeted therapy, it's not a guarantee that it will work. Sometimes we put you on the targeted therapy, and this can happen with chemotherapy too. Not everybody responds. Some patients have cancers that are just really smart or have other mutations that help it escape and get around that targeted treatment. So it's not a guarantee. It is more likely to work for you, but we can't say that it absolutely will. And it's not a cure. It tends to work for a while, and then the cancer finds a way around the therapy. We've watched this actually happen in some of our patients. We've had patients with BRCA mutations that we were able to get a targeted therapy for that worked really, really well. And then after 9 months or a year, the therapy stopped working. And when we did additional biomarker testing, we could see that a second BRCA mutation had formed. And the research showed that second BRCA mutation helped the cancer to avoid the treatment. So it developed a second mutation to get around the treatment that we were throwing at it so that it could continue to grow. And your cancer is made up of your human cells, which are very, very smart. And it's unfortunate that they are so smart that they're constantly trying to figure out a way to survive whatever we throw at them when we don't want them to survive. But they've spent your whole life trying to keep you alive. So that's why they're as smart as they are. Questions on targeted therapy before we start talking about cost, which is not the favorite topic.
Now, do doctors all do blood work when you're getting a targeted therapy? Say, now, for instance, I'm on an estrogen inhibitor. Is there any blood work, or how do they check to see if that's being effective, other than, well, you don't develop cancer while you're on it?
We look, that's a great question. You know, we look at tumor markers in some patients, if those are an indicator for that patient, if the drug's still working. We do scans, you know, to see if it's still working. And obviously the reason that we want to see you periodically is to know if you're having any additional symptoms. But we're just getting to the point where we have the technology to look for things like circulating tumor DNA or ESR1 mutations that can tell us that that therapy might become less effective in the near future. So I don't think we're really completely there yet, where we could do a blood test and say, okay, you know, your estrogen therapy is probably, we need to be watching because it's probably not going to work that much longer. But we do, like, we have a clinical trial right now that's looking at patients on an estrogen blocker to see if they're developing an ESR1 mutation before they progress, so that we can add a medication, an experimental medication, to your current therapy to see if we can keep you on your current therapy for longer before you progress on it. And we don't know if that'll work. We're
Can you
trying,
tell me what that, can you say what that was again, developing a what?
ESR1 is it's a mutation that we see often.
Was that, I'm sorry, was that ESR1?
Hmm?
ESR1, is that what
Yep.
you said?
Yes.
Okay.
Yeah, it's a mutation that we see in most estrogen, in many estrogen receptor positive breast cancer patients who develop resistance to their estrogen therapy. And so we know it's one of the mutations that leads to resistance to your average aromatase inhibitor, like anastrozole or letrozole, or exemestane. We will see you start to develop resistance to that, and in many of those cases we'll find that you've developed that ESR1 mutation.
So, and how do I, what would I ask my doctor to check to monitor that?
Well, we'll go into the testing, but it does require one of those molecular tests that we talked about. So they could do it on your blood to look for that mutation to see if you're developing it.
And are these studies that are doing that, are they closed already?
Nope, we have studies open, and they are kind of particular about which patients can go on them. So right now, the current study that we have open is for patients who've been on Ibrance, along with an aromatase inhibitor, in patients who aren't progressing but have been on that therapy for at least 6 months. But they don't allow patients with bone-only disease, which is the case for many of our patients. You have to have some kind of disease that we can measure or monitor. But we're looking at patients all over the practice to try to find patients who fit those criteria.
Okay, thank you.
Yeah. Does anybody else have a question? Yeah,
Yeah.
Peggy.
Some of all this new targeted therapy, it's what, just about 5 years old, or is it older than that?
And there's some targeted therapies that are older than that. Like we've been giving EGFR therapies for colorectal cancers for the whole time I've been a nurse, so at least 13 years. And I think for lung cancer, probably for that too. And then for breast cancer, the hormone therapies have been around for quite a long time, but there are many that are very new, like less than a year on the market.
Okay.
Yeah, so there's a lot of research into this right now.
So does the research show that if it's working, it lasts about 2 years or 3 years? I know you'll say it's individual for each patient.
It is really individual.
Are there some studies where patients have lasted a long time?
There's always anecdotal reports where some patients have gone a really, really long time with no progression. The HER2 patients are great examples of that. There's patients with metastatic HER2 positive breast cancer that have lived for decades, but that's not true of every patient. You know, we have patients with HER2 positive metastatic breast cancer that progress quickly, you know, Their cancer's got something else going on that helps them get around it. So it is really, really different for every patient. We can say that it's more likely to work than if you don't have a target, or if we're just, it's more likely to work than a non-targeted therapy if you have that biomarker. But it really, for every patient, it depends how long you go before it stops working. And they do tend to stop working.
Thank you.
You're welcome. Is there anything else? All right. Moving on to the cost. So biomarker testing can definitely be expensive. As this has gotten more common and more recommended, the cost has started to come down. And insurance does cover it more often than it did 5 years ago. But it's still very expensive. And I get those phone calls from patients when they get the explanation of benefits from their insurance provider, and they're, understandably shocked by how expensive this kind of testing can be. I think the last time I talked to Foundation Medicine, they were charging almost $7,000 for tumor testing to your insurance if they covered it. So it can be very expensive. We're able to get this testing for our patients. We can get a cash pay price of $650 if your insurance won't cover it, or most of our patients qualify for financial assistance programs to get the cost of testing down to something that you can afford. It's important to check with your insurance company if you're concerned that it's not going to be covered. If you have metastatic cancer, it's much more likely to be covered than if you have early stage cancer. So a lot of times we will go in and try to get financial assistance before we order the test for patients who are not metastatic. Sometimes we can get you into a clinical trial that will test biomarkers at no cost to you. So right now we have clinical trials for pancreatic cancer and lung cancer that will get you some biomarker testing, even if it doesn't have a treatment specific, but it'll help cover the cost of that testing for you. And there's some patient advocacy groups that can help you find biomarker testing if you need it. So particularly, I think for lung cancer, ovarian cancer, stomach cancer, pancreatic cancer, liver cancer, and prostate cancer, there are advocacy groups that we can get you information for that can help get the cost of biomarker testing covered if your insurance won't cover it. So like I said, find out what your insurance covers. So check that coverage brochure. There's public programs through those different companies, and this link, which will be in the information that's emailed out to you after this meeting, hopefully will be spelled correctly because community has 2 M's. Cancer Support Community can also help you find out about costs. We work at Northwest with patients to appeal denials from insurance, make sure that they have all the information they need, and help patients apply for financial assistance programs when needed to cover the cost of testing. All right. So moving on to genetic testing, which I've already done a whole workshop on before. So this literally could be an entire workshop all by itself. But we're just going to briefly go over genetic testing and when we use genetic testing of your germline mutations that you were born with, your own every cell in your body kinds of makeup, to figure out if there's a treatment for you. So genetic testing may be offered or recommended because you have a cancer that has a higher number of people who get it through an inherited means. So some cancers are not usually inherited from parent to child, but other cancers like breast cancer and ovarian cancer are frequently inherited from parent to child, and more frequently. So we want to test for a genetic mutation to see if that's contributing to your disease and could make a difference for your treatment. And also so that if you have children or close relatives, we can make recommendations on whether they should be tested as well. If your family history suggests that you might be at risk for cancer because maybe your mom had cancer and her sister and your cousin and your daughter have all been diagnosed with cancer, even if it's not a tumor that we would normally see passed down, or even if they don't seem the same, like maybe some of those people had pancreatic cancer and some had prostate cancer and some had breast cancer, it still could be part of a germline pattern. And so sometimes your family history will inform genetic testing and lead us to believe that you need to have the genetic test done. You've probably heard of inherited cancers, and I think a lot of us like to take a little bit of comfort, like, oh, cancer doesn't run in my family. The part that's inherited is not the cancer. You don't inherit breast cancer and you don't inherit ovarian cancer, but you can inherit the mutation that makes you more at risk for those cancers. It's the change in your genes is the part that's passed down. They're not giving you that cancer at birth. It's not like asleep inside you somewhere just waiting for its moment. But you do sometimes have these mutations that are kind of smoking guns in there, waiting for their chance to wreak havoc. The genes are those pieces of DNA that pass from parents to offspring. So if you've inherited that gene from one of your parents, you could pass that same gene along to one of your children. This is not as common as we would like to think it is. It's about 5 to 10% of all cancers are linked to a genetic mutation that you inherited from your father or mother. So the vast majority of cancers, 90 to 95%, are not. They're just random. Or in some cases, they can be caused by like environmental exposures and risk factors like smoking and obesity. But most of the time, it's just bad luck. It just happens. It's not inherited. It just happens. We don't test every patient for inherited mutations. We look at what type of cancer you have. What are the characteristics of your cancer? If you have a gastrointestinal cancer like esophageal or colorectal, we can look at the tumor when they take it out or at your biopsy to see if it's got certain characteristics that make us think it could be inherited. And we look at your family health history. If you know your family's health history, not everyone does. We can look sometimes at your age or race and ethnicity to help us know. There's certain populations in the world that have a higher risk of developing cancer. If you develop cancer at a younger age, sometimes it can be a sign that it was due to an inherited mutation. And we also look at whether getting these results is going to affect anything in the future. Like if you don't have any children and don't plan to have any children and don't have any living relatives, and that it's not going to impact what kind of treatment we give you, then does it really help us to know if you inherited your cancer? It doesn't change the fact that you have it. So why bother paying for the testing? So, we look at all of those factors before we decide whether to run a germline genetic test. It's not just for people with cancer. So if we found out that you were a carrier of a gene, we would want to find out if maybe your family were carriers. So a lot of the companies and labs that do this testing will offer what we call cascade testing. So if your test comes back positive, then they'll help cover testing for your family members to make sure that if they want to know, that they have the opportunity to get that test and know. And we call this genetic testing for inherited cancer risk. When you're concerned about cancer based on your family history and situation, a lot of times we'll refer you to a genetic counselor, or you'll talk to somebody who's been trained specifically in how to assess these kinds of family histories and what kind of recommendations should be made if you have one of these mutations. So they'll order the testing and then they'll help you interpret those results when they come in. And that those genetic counselors are priceless when it comes to trying to understand this. They understand the inherited cancer risk sometimes better than your oncologist does, because it's their area of expertise. So if you found out that you had an inherited mutation and maybe your daughter got tested and she had an inherited mutation, it would be important for your daughter and yourself to speak to a genetic counselor about what does that mean for her future if she doesn't have cancer right now. What should she be doing to prevent cancer in the future? So in the past, we typically use this test mainly to see if you inherited the increased risk and if your children could be at risk. But now we've found that germline mutations can also be biomarkers that can impact your treatment options and lead to a targeted therapy. And the most well-known and common mutation where this is true is BRCA. If you test positive for a BRCA mutation, we now have targeted therapies for that BRCA mutation, even in the germline, not just in your tumor. So we have approved BRCA PARP inhibitors, or what they're called. That's what the targeted therapy is called. And it's been approved in ovarian cancer and in certain types of breast cancer. And now we're also able to typically get it for prostate, pancreatic, fallopian tube cancer, and primary peritoneal cancer. So it's approved for multiple different kinds of cancers where that germline mutation is present. By knowing that you've inherited a BRCA gene, your doctors can prescribe this therapy. So it's important in those kinds of cancers that we're looking for it. So biomarker testing versus genetic testing. This is also called like genomic testing versus genetic or germline testing. These terms are complicated and difficult. I think it's hard to tell them all apart. But there's two types of tests. There's tests for the inherited genetic mutations, or what we call germline mutations, that increase your risk of cancer. And then there's tests for the biomarkers that are driving your cancer to grow. So the biomarker testing is looking at the tumor's genes. So we're specifically trying to look at the tumor DNA and figure out the best way to treat the tumor, whereas the genetic testing is looking at your genes that you were born with. The one test where we're looking for your genes, we take a sample of your cells. So that could be your normal blood cells, or it could be a saliva test or a swab of your cheek. Sometimes we do a skin punch biopsy in certain cases. We look at it under a microscope and we look at your genes. Whereas when we're looking at the cancer genes, we need a sample of those cancer cells, either via a biopsy or a specific blood test that's going to pull the circulating tumor DNA. Then they do the biomarker testing, and they're testing the cancer genes for the therapy. So they are two different things. Genetic testing is the one that shows if it's more likely that you would get cancer than somebody who didn't have that inherited change, or that your children might be at risk for cancer, or your other relatives. And in some cases, it can also work as a biomarker that we prescribe treatment for, like we talked about with the BRCA. But biomarker testing is used to determine what subtype of cancer you have and if there's a targeted therapy for that. The results of biomarker testing can offer more information about your particular cancer and how we treat it, not just your makeup and how you were born. So we do have BRCA genetic testing and BRCA biomarker testing, just to make life confusing for all of us. BRCA genetic testing is recommended in all women with ovarian cancer and some women with breast cancer, certain women, depending on your age of diagnosis and your family history, which subtype of breast cancer you have. And your doctor can use that BRCA genetic testing, and it might change your treatment options. We're also testing BRCA in most pancreatic cancer patients now. BRCA biomarker testing. So even if you had the genetic test and it was negative, which many of you, if you have breast cancer, probably did have this test done. if you have advanced or recurrent ovarian or breast cancer or pancreatic cancer, we'll probably test the tumor for BRCA as well, because the tumor itself could get a BRCA mutation that you didn't inherit. It can develop it all on its own, and it's just in the tumor. But we can use the same treatment to treat the mutation in the tumor, whether you were born with it or whether it came up on its own. Does that make sense to people? Does anybody have questions? I feel like this is complicated. This is the complicated part. Okay. So we are just about to the end. We're getting close. Here are some resources that'll get emailed out to you. You've got the Cancer Support Community, the American Association for Cancer Research, the American Cancer Society, and the National Cancer Institute. They all have articles specific to precision medicine. And I've been on the Cancer Support Community's website, and I know they have other recordings of this presentation that might be better than this one. So if you want to review, maybe find another presenter and see if they do a better job. We want to talk a little bit more about more resources. So these are just different other ways that you can get involved. The Cancer Experience Registry is a research survey that's used to identify and understand emotional and social needs unique to your cancer experience. It helps us know what we need to do to improve the quality of care we're providing for you. These surveys are confidential and secure. And you can join the Cancer Experience Registry at cancerexperienceregistry.org. So there is an informed consent with that. It'll tell you exactly what you're agreeing to. You do have to have an email address and fill out a profile, and then you fill out the survey and set up your page, and check back for educational resources and new surveys. mylifeline.org has interactive blogging and updates. It's got a calendar, discussion boards, care coordinators, privacy controls. I haven't been to this site, so I can't tell you what all is on it, but I think it's a site that helps you let your family and friends know how you're doing. It's similar to Caring Bridge. If you've used that, they'll email your friends when you posted an update. So if you have a lot of people who are wanting to keep up with your cancer journey, this could help. There's also a way to coordinate volunteers to help you with meals. If you have a lot of people offering to help with meals or rides or childcare, anything like that, it's got a calendar to help you organize that. And it's got discussion boards to help you connect with other people that are going through similar things to you. It helps you organize your volunteers if there's people who really want to help you. It can be exhausting sometimes, especially when you're first diagnosed. Everybody wants to help, but you don't know how to parcel that out. So this is a site that can help you figure that out. So just to finish up, what questions do we have after the super confusing genetic versus biomarker testing, and anything else that's come up over the course of the presentation?
It isn't your role to talk about the various drug treatments. There's the Ibrans, and then there's some more.
There's many, many, many different therapies. It's best to talk to your doctor to know which of these therapies are best for you in your personalized precision, space. But yeah.
Okay.
Mary Jane, did you have a question?
Yes, a comment. When you were talking about genetic testing, I kind of glazed over because I have no clue who my birth parents are. I do wonder if you've been on targeted therapy for a couple of years, which is what my oncologist said it would probably be for me if we go that way. Then do you do the close, because they've been watching me every 3 months and stuff, do they do that close scrutiny of how you're doing? Or do you have to pay attention to your body and say, oh, I think I have a problem?
Are you saying after you've been on it for a while?
Yeah, after you're done and it looks good. and then do
I think it depends a little bit about kind of where you're at. If you already have metastatic disease that's traveled from the site of origin, they're always going to keep monitoring you.
sorry.
With adjuvant therapy, where you've been treated curatively and had surgery, and now you're on a hormone therapy for 5 to 10 years after your surgery. Once you're done with that therapy, they monitor you less frequently for recurrence because the hope is that you're cured. But for metastatic patients, when that first therapy stops working after a couple of years, they're going to change to a different therapy, and they're going to watch you just as closely on the next one to see how long it works. Does that help? Does that answer your question? Okay, good. Anybody else?
Yes, I have another question. If you have early stage breast cancer and you're doing a what is it called?
Exemestane.
Yeah. Is there any monitoring that should be done? I know with the doctor I'm seeing, they basically say, oh, we'll see you the nurse will see you in 6 months and I'll see you in a year. That seems kind of, that concerns me that there's not more monitoring going on. Is that pretty typical?
I think that's pretty typical for a lot of our doctors. I mean, some of our doctors want to see you every 3 months for maybe the first year. But if you're doing well on your therapy and you're not having significant side effects to it, then 6 months is somewhat typical if you have a really low risk of recurrence.
And how do they know if the medication is really effective at what do they call it? Keeping the estrogen from growing or keeping it from getting to.
That's where the clinical trials that got those drugs approved come into play. So, they know from past experience with many patients who've gotten the hormone blockers that they're very effective at blocking the estrogen. But they still want to see you periodically. And it is still important to let your oncologist know if you have any new symptoms that are concerning, like new pain, new bone pain, new headaches, just new things that you haven't experienced before. It's important to relay those so that they can be investigated to make sure something isn't going on. But those drugs are very effective, and that's why they can be so confident with those longer intervals between seeing you.
I see. And when it is the estrogen blocker, if you have had a total hysterectomy and ovaries removed, is it still as effective? Do other glands and other parts of your body produce estrogen?
Yes. So there's other places that estrogen comes from in your body. So your body's producing less of it, but the drug is blocking your cells from being able to receive any other estrogen that happens to be floating around. So it's, working extra hard to block the estrogen from being able to grow any cancer cells that might have, escaped your curative treatment.
I see. Thank you very much.
You're welcome. That was a great question.
This has been very useful information. I do appreciate.
I'm so glad to hear that.
the time and the effort that you've put into this, and to share it with us. I find it very useful.
Good.
Thank you.
This was
Yeah.
a wonderful presentation, and you have been studying well.
Well, thank you. I really love to learn, and that's what got me into this mess, right? But
And you present well, and we're very grateful.
well, thank you so much. That's so kind. I'm glad that it was useful. That's what we're hoping for, right?
Yes.
All right. Well, I'm going to go ahead and stop the recording, and then Catherine will go ahead and give you some updates about our chapter, and then we'll do the raffle at the end. So please stay on. So here I go. For everybody who's not watching this live, we're ending the recording. Thank you so much for watching this presentation.